We're excited about bringing the program to you today. This is, you've landed on the webinar for the Sight and Sound Bites bi-weekly seminar series that we have been doing now since April. And this is coming to you from the Eye and Ear Foundation. It's our lunchtime educational webinar series of research and clinical innovations at the University of Pittsburgh School of Medicine. Today's topic is simulations in tracheostomy care. We're talking about teaching parents and caregivers to care for critical airways at home. This is going to be presented by Dr. Allison Tobey, Director of Tracheostomy Care Education Programs at Children's Hospital of Pittsburgh. I'm Lawton Snyder. I'm the CEO of the Eye and Ear Foundation. The Eye and Ear Foundation supports research at the two world-renowned Departments of Ophthalmology and Otolarngology here at the University of Pittsburgh. We work very closely with the chairman to follow their their vision, and we support this through the funding that comes in through the Eye and Ear Foundation, and we support the research that advances care for all of you. And that philanthropic support is certainly the most important thing to make sure that we're able to do just that, advance care for patients. Before we start today's program, I'm just going to go through a few housekeeping items. This is a Zoom product, which you're probably used to using, but this is the webinar program. And for this purpose, we do not have chat enabled, so you'll won't be able to use chat, but we do have questions and answers open to you. So you see a little bubble down below. It says Q&A. Please click on that and type your questions during today's program. Please refrain from asking personal health questions if they aren't something that the whole audience would want to hear. If there are any questions like that, you can certainly send us an email that we can follow up with you later. And that email is in your invitation, Mr. Craig Smith. Tomorrow, you'll receive a survey via email to provide us with feedback. You'll also be added to our email list to receive information on future webinars. It looks like Dr. Toby hopefully is ready here. But I'm going to first introduce Dr. Jonas Johnson, our Distinguished Service Professor and Chairman of the Department of Otolarngology at the Eugene N. Myers and the Eugene N. Myers Endowed Chair at the University of Pittsburgh School of Medicine. Dr. Johnson, always a pleasure, and thank you.
Well, thank you, Lonnie, and I'm delightful to sort of be the middleman to introduce Allison Tobey. Dr. Toby, of course, finished her residency training in otolaryngology, and then she did fellowship training as a pediatric otolaryngologist. So she comes to us today with very specialized capabilities as not only a surgeon and a physician, but a teacher. So with that, Allison, I think you should take it away. Thank you.
Okay, great.
Okay, I think we'll need to turn off the one that the phone maybe.
Trying that.
Okay, so it looks really good on your computer now.
Okay, can you hear me now?
That's much better. Thank you.
I cannot hear anyone.
Allison, you're good. We can hear you. You're ready to go. You're ready to go.
Okay, perfect. Okay, so I'm Dr. Allison Tobey. I'm one of the airway surgeons at the Children's Hospital of Pittsburgh. I have the distinct pleasure of taking care of a lot of critically ill kids and critically ill kids with airway abnormalities. I wanted to just thank the Sight and Sound Board for inviting me to talk about something I'm very passionate about. Also thank you guys all for logging in and to listen to something that probably is a little bit off your typical topic. Simulation in tracheostomy care is relatively new. I'm going to start with a few things just to kind of introduce the need for it and what most of our families go through, just so you guys can get a sense of what it's like to have a child that has quite a bit of medical needs and has a critical airway to take care of. So as far as disclosures, I do have some. Some of this funding for the simulation project, as well as an education book, some of the funds were provided by the Beckwith Institute. So I thank them for all other money. So simulation and tracheostomy care. So we're going to start off with talking about what a tracheostomy tube is and why it's needed. I understand that probably the vast majority of you have never had a child or a grandchild that has had a tracheostomy or has had a significant airway issue, and maybe never even had significant medical issues. I'm going to try to have you guys understand what it's like to have a child that has a tracheostomy tube, and briefly explain how in the past, we've trained caregivers, and how we are moving to change that to improve the care that our caregivers can provide to their kids at home. And then I'll talk a little bit about why we need stimulation. So when you're thinking about a tracheostomy tube, and one, you have to go back to kind of the basics of breathing. Breathing is something that you and I take for granted. Most of us out there can breathe easily through our mouth or our nose. Sometimes a small cold or allergens might make that a little bit more of an inconvenience, but it's not something that we struggle with. However, for many kids, this is something that they struggle significantly for. Kids that have chronic lung disease, specifically those at prematurity. With all the advances in medical science, we have a lot more premature kids living longer and healthier lives. But with this does come some chronic lung disease, and specifically in the first year or two of life, it is a big hurdle to overcome. You can have chronic lung disease from aspiration or other neurologic abnormalities. This is also something that can affect a lot of our children that we see here, and unfortunately can be devastating for a lot of children, and having a tracheostomy tube helps them get home and be able to manage some of the aspiration. Other things that can contribute can cranial facial obstruction or any narrowing of the airway. So some kids are just born with small jaws, facial abnormalities such as skeletal abnormalities make it really hard for them to breathe, especially in the first years of life. And then sometimes in the process of trying to save children's lives, either from prematurity or from traumas, they have to have prolonged intubation, which then can also cause some scarring of their airway. And so sometimes a tracheostomy tube is needed for that. So what is a tracheostomy tube? It is essentially an artificial airway that bypasses any upper airway obstruction. It does allow for us to better ventilate the lungs because we bypass the mouth and the nose. It's also a more comfortable way to ventilate the lungs. If you have a significant respiratory issue that is prolonged and you needed ventilation, your options are to have a breathing tube and be sedated, or to wear a mask over your face, which can be very uncomfortable and often doesn't fit many of our kids. And so having a tube that bypasses that allows for us to give the ventilation that they need, yet they can still go on and do some of the developmental things they need. If you think about a neonate who is in need of respiratory or positive pressure because of their chronic lung disease, if they're in bed because of a breathing tube or because of a mask, which limits their mobility, and they need the positive pressure for 6 to 9 months to sometimes even a year and a half, if they're tied down to tubing into a bed, they won't be able to sit up, they won't be able to develop crawl, walk, and all these other things that are important to developmental staging of children. The other thing that a tracheostomy tube allows, it allows for us to treat lung disease better. So if a child is aspirating, or if they have really bad inflammatory disease where their lungs are getting sick and they're getting a lot of mucus, but they're not able to clear it, we can manually or clear secretions better through a tube in the neck than we can through the mouth. So pediatric tracheostomies are not that common. About 4,000 to 5,000 pediatric tracheostomies are performed per year in the US. Most of these are performed in children under a year. Most of them are because of chronic lung disease. At Children's Hospital, we do about 60 per year. Vast majority as well is reflective of the national trend, and they are kids under a year. Most of these have more than one other comorbidity, either a neurologic issue or a gastrointestinal issue or cardiac issue is probably one of the most common ones. And the vast majority of these kids need some type of mechanical ventilation upon discharge from the hospital. So not only are these families having to go home with a child that has multiple comorbidities, they have an artificial airway in their neck, they often have to go home with respiratory support, which adds additional equipment. The morbidity and mortality also of children that have tracheostomies is very high. And most of these families are well aware of these data. One of the first things many families do when you talk to them about having to place a tracheostomy tube, they are on Facebook, they are on mommy blogs, and they are talking with families. And the morbidity and mortality is high. Across the US, and one of the nice things about having big databases for Children's Hospital is, to other children's hospitals across the US, is we can look at the major morbidity and mortality in certain populations, and so we can look at that data nicely. And within the first 30 days after surgery, about a quarter to almost a half of kids have a major complication, and about 6% will die. Most of those deaths are not necessarily related to the tracheostomy tube itself. That rate is probably somewhere around 2%, but it averages between less than 1% to 5%. Most of the morbidity is related to the other comorbidities, and the most common ones being the cardiac abnormalities and the pulmonary abnormalities. But children under the age of 1 have much higher morbidity and mortality. So parents know this, and they know this, that they're going to be taking home a very fragile kid. And so they are very anxious, and I'll get to that in a little bit. I just wanted to bring one more thing that kind of comes up when we talk to healthcare providers, that tracheostomies are very costly. They are very costly within the first few months after they are placed. The amount of hospital care that goes in is high. Most families are being seen in the emergency room multiple times within the first couple months of being discharged home. A lot of this is because of anxiety. A lot of this is because of things that could be prevented with better education, such as mucus plugging. That is where the tracheostomy tube gets clogged with essentially secretions. Most of these visits are related to some type of respiratory issue, about 50 to 60% of them. And that's very costly to the healthcare system. The other thing that's very costly is a lot of these children are not close to large pediatric hospitals, and therefore, if they are seen locally, they are either life-flighted or transported to a pediatric hospital maybe 4 hours away, which is also extremely costly. And so maybe better educating some of the outreach hospitals and caregiver providers would also benefit. Some smaller hospitals, if you come in with essentially a cold and increased nasal secretions, and what anyone else would say, this is just a viral URI, will treat it symptomatically and send you home. A child with a tracheostomy tube, they will frequently just fly them down to Pittsburgh. So some of those things I think would improve if we had better education to outside providers. So this talks a little bit about emergency room visits. This is Pittsburgh hospital data. After discharge, more than 50% of patients will have at least one ED visit within the first 30 days. A quarter of them will have more than one visit. Most of these visits are related to respiratory issues, not necessarily tracheostomy issues, but respiratory issues, mostly thickened secretions or changes in secretion management. This is things that we think can be better managed with better patient education, as well as providing access to patients via portal system or via online office visits, which we hadn't had prior to COVID. So one downside, COVID brought a lot of things, but one of the big benefits of COVID is Children's Hospital now has a virtual way to see patients virtually, and these tracheostomy patients can benefit from that significantly. Most of these office visits, or most of the emergency room visits, do result in admissions, mostly because of travel time, not necessarily always because of medical comorbidities. So caregiver burden is also another thing that I just wanted to mention, because as most of you guys, like I said, have not probably had a patient that has had significant medical needs, or have a child has had significant medical needs. But having a tracheostomy tube comes with a lot of equipment. It comes with a lot of financial costs out of pocket, as well as healthcare costs. You have to have 24-hour care for the patient. And with 2 care providers is what we recommend at all times. So if you can't stay awake for 24 hours, and I don't expect anyone can stay awake for 24 hours, 7 days a week, 365 days out of the year, you're going to have nurses in your house. And you're going to have nurses staying in your house for long shifts. And so that in itself is a big inconvenience to families. There's also increased costs from travel expenses. They're often traveling more than 3 to 4 hours for their typical routine care, because locally they cannot get the care they need. They have an increased cost in their utility bills. They have a suction machine. They often have a ventilator system. They have a compressor for their oxygen. All these things cost money. Because they use electricity. A lot of these families also have to modify their home and their vehicle because of all the equipment that comes with transporting these children. At all times, the suction machine and the ventilator have to be in the car, accessible. They can't be in the trunk. And so sometimes these kids have wheelchairs and things like that. So they have to have modifications to their home and vehicle for that. There is quite a bit of out-of-pocket cost. Also loss of work. A lot of times one caregiver or family member is not able to work because of the amount of care that they need to provide for this kid. There's also like sleep deprivation if they can't get home nursing care. This is a big problem in Western Pennsylvania. There's a big lack of qualified nursing out there. And most nurses are very hesitant to take care of younger pediatric tracheostomy kids. They scare them. You even ask our nurses in our tertiary ED here at Children's Hospital, and neonatal or pediatric infant tracheostomy tube kids scare them. There's social isolation limitations. A lot of these families can't do what is considered normal because they have a child that has a lot of equipment that comes with them, and they have special needs. Also for families, when they are thinking about the idea of having a tracheostomy tube, there's a lot of foreign equipment and technology. They have to learn to use a compressor. They have to learn to use a ventilator system. They need to learn to troubleshoot this equipment. And that is all new. And some of these families are very young and are not well educated. And so that is a big burden. And then there's just the emotional stress of having to care for a medically fragile child. So when we talk about placing a tracheostomy tube, we do bring up some of these issues with family because we want to prepare them for changes. However, most of the time when we see these families, they've already been in the hospital for 3 months. For the most part, they are neonatal kids that were born premature. They're tired of having a breathing tube or a breathing apparatus attached to their child's face for the last 3 months. They've watched their child suffer several times, usually when the tubes are trialed to be removed. And so they're ready. They're ready to have something done because they want to go home at that point. And so for most of the time, convincing families to proceed with a tracheostomy tube is not the hard part. Preparing them for what is to come next and what is to be expected with having a tube is a little bit harder. It's a journey, and all of these journeys have ups and downs. There's good times, there's bad times. They will cry, they will laugh, and they will smile. Not everyone's journey is the same. Some people have a tube placed, they are put on a ventilator, they wean from the ventilator, and the tube comes out relatively quickly, and they can go on. Other times, that tube might be with them for very long periods of time. It comes with a lot of baggage. There's a lot of equipment, as I mentioned before, that comes with having a tube. And oftentimes they have to just get used to moving with all that equipment. A lot of these families come to the hospital with wagons. They just have a wagon, they put the child in the wagon as well as all the equipment. It requires other adjustments just to their life in general. And these families are going to have to learn new skills. They're going to have to learn to take care of this trach. They're going to have to learn to troubleshoot the equipment. And we will get them there, but they will not be able to leave the hospital until they can do that. And our goal is to have these families be able to care for this child and have them happy, healthy as possible and live their life as normal of a life they can. And so how do we get them there? So once the trach is in, when we do start to teach them to care for the trach while they're in the hospital, but then we also ultimately want to prepare them for home. So we do this with educational booklets, with videos, and hands-on training on the child. We also have recently started the simulation lab, and this I'm going to talk to you a little bit more. The downside to educational books is people will read a book and will read about what to do in a case of emergency. And it's one thing to read it. They kind of have this assumption that's never going to happen to them. I'll tell you that if you've had a tracheostomy tube, a child with a tracheostomy tube for more than probably 6 months to a year, that tube's going to come out accidentally at some point, especially toddlers. They pull on stuff. They're smart enough to know how to take off these ties. It's a foreign body. They want to play with it. They want to put things in it. So things are going to happen. And so it's really hard to tell people that things are going to happen either through a video or through an educational booklet. When we do the hands-on training, and I'll kind of go through some of the stuff that we do, we are mostly teaching them to care for the trach, to clean around it, to change it, to suction, things like that. But we are not going to put the child at harm to simulate an emergency event. And so that's where simulation comes in. So one of the things that I talked about is we have educational material. So we start this process once the tracheostomy tube, either the discussion of the tracheostomy tube has been made or once it's in place. And we help the families understand what a tube is, what are the parts of a tube, and talk about ways that we clean them and some of the equipment that's involved. And we recently, with part of the funding from the Beckwith Institute, have redesigned our education booklet, and these are some of the photos from that booklet. We also introduce, prior to them going home, a lot of the equipment that they're gonna have. And like I said, there's lots of equipment. There's suction machine, there's pulse oximetry, there's air compressors, and then there's the ventilators. And they often have versions of this that they travel with and versions of this that stay at home. And so we teach them basic care, so just how to clean the tracheostomy tube. All of these things, the changing and the cleaning, other than suctioning, we do typically tell families that they should have 2 caregivers present at all times. We also, which is something that you might not think about, is we have them travel at all times with 2 caregivers. So if they're going to go to the grocery store, if they're going to go to a doctor's appointment with their child, there's always 2 caregivers. And I don't know about you, but often my husband and I can't both be off to take one child at one place. So this is something that else is also an inconvenience. We talked to them also about changing the ties, changing the trachs. We do a lot of this in the hospital with the nursing staff. One of the things that we have, feedback that we've gotten from families is it's really nice to be able to do this in the hospital with the nurses present, with the respiratory therapist present, and the physicians present. We often have them before they leave. They are required to do it by themselves, but they are still doing it in the hospital setting. They know the nurses are around. They know the respiratory therapists are around. If they have any problems, they're in a safe environment. And for many of these families, they feel like this, simply changing this tube, which needs to be done on a weekly basis and more frequently if there's a lot of secretions, they feel like this is the most terrifying thing. What happens if they can't get the tube in? The child is squirming. The tube, kids heal very fast. So if that tube stays out for a very long time, that opening can close up relatively quickly and the tube might not go back. And for some of these kids who don't have an upper airway, either they have stenosis or scarring up above, or they have something blocking the above, like a tumor that we're waiting to resect, they might not be able to breathe without having this tube. And so parents are terrified about this. And so they do it by themselves before they leave, but it's in a hospital setting, and families sometimes feel like that's not the same as doing it at home. And so, and this also reflects some of these comments that families had sent me when I asked, what were you thinking when you were preparing for home? And most of them they were terrified. They really doubted their ability to take care of their own child. They were nervous. They didn't want to go home. And these are some of the things that I can't change their child's medical needs. I can't change the financial burdens and the changes that having a medically complex kid is going to do to these families. But we can change some of the anxiety that goes with going home. And so simulation was one of the things that we set up to try to help do that. And so our goals were to provide a realistic environment where families could run through emergency scenarios in a safe, controlled environment by themselves. And like I said, we're not gonna, as opposed to how we teach them to care for a trach tube, to clean a trach tube, change a trach tube in the hospital setting, we are not gonna put our child at harm in order to create an emergency situation. So the simulation lab allows us to create an emergency situation that the families have to struggle through. We wanted to improve caregiver comfort and confidence with taking care of their fragile child. We wanted to make sure that they knew when to call for help, and when to do an emergency trach change, and how to troubleshoot during a high intense stressful situation. So first things we needed to do is we needed to create a simulation lab, and we wanted to create a space that was more home-like as opposed to more like a hospital room setting. We needed to get the equipment, and that includes the suction machine, the compressors, the ventilators, as well as all the disposable stuff that comes with the trach. We needed a mannequin that had a tracheostomy tube and also had the ability for us to adjust the vitals. And this was a big problem because when we started this project, there was not one readily available. There is now one that's on the market as of about the last 3 months, but that was not the case when we started this project. So we had to modify a mannequin that we had so that we could use it with a tracheostomy tube. We also needed the programs. We needed to create the scenarios and program into the simulation package. We also needed the time, and the time not only for us to do this project, but also to have families come in. And I'll show you a few pictures from when we do run through the scenario. We have to plan for 1 or 2 of the family members to be here. So oftentimes it's after work hours. We also need the simulation lab to be present. We need the respiratory therapist and us to be present to go through. So coordinating a time when about 6 to 8 people can be together in one place was often a limiting factor. Not to mention, when we got this up and running, COVID happened, and then so we had to shut down. So that was another little hurdle that we came upon. So this was essentially the simulation setup. We wanted to have families take some type of pre-training survey. They also had, before any simulation, they had what we had typically used as pre-training. They had the booklets, they had the hands-on education for just daily care, and they had the videos that we have. So they've already had all that other education that we provided for them. We would do the online simulation class. We would then also bring them in and have we would have them run through the scenarios. We video the scenarios so they can watch the videos afterwards. We do debriefings, and then we have them fill out a post-training survey at the time of, immediately after they finish the scenario, and then also 8 weeks after the simulation. So we created, with support of Wiser, we created 4 scenarios, and we utilized a simulation lab that was at Children's Hospital. It wasn't necessarily home-like feeling, so we had to do some modifications for that to make it feel more home-like, but it's done. And this is, in the background here, is one of the moms who was going through the simulation course, and then I'll show you some additional pictures there. This on the right-hand side is the questionnaire that we use pre and post simulation, and it's a 5-point Likert scale. We gave this 5-point Likert scale questionnaire to all caregivers before they completed the simulation, and then after the simulation, it's the same questionnaire that goes out 8 weeks afterwards. Each caregiver ran through all 4 scenarios. We didn't stop after each scenario to do a slight debriefing. We did video each scenario so that we could go back and make sure we reinforced what the families did well, ask them how they felt, ask them what they thought they could do differently, and then we provided our feedback on what we thought we could do differently. This is another example of the technology and what the SimLab looks like. We've had 7 families complete this to date. Caregivers and comfort level and confidence all improved after simulation. The average pre-questionnaire Likert score was just about 4, and it was above 4 afterwards. Minimal difference, but I will as I'll show you on the next slide, families did have significant comments to state that they benefited significantly from this. As far as some of the data about, did this help actually medically, of some objective data, we did have still, of these 7 families, we had 2 patients that did have 1 ED visit within the 30 days after discharge, and one of these was a trach-related or respiratory-related issue. It was increased secretions. So the number of ED visits, maybe not so much down, but the numbers are low. We're hoping that we will ultimately, if we do more of this simulation, we'll see that these emergency room visits actually do go down. We did get a lot of positive feedback from families, and these are just some of the comments that families had. So I think overall, this was a unique opportunity for families to run through very stressful situations. This mom that is in the background here did run through an environment, and I have a picture where she looks very panicked. And she said it was very good for her to feel panicked and be able to calm herself and go through all the steps that she needed to. So our next steps for this lab is we'd really like to extend this to other healthcare providers. There are several times that I've been in the emergency room where the nursing staff or even the EMTs that come through, they're not very comfortable with dealing with these kids. And this is reflected in the fact that we have a lot of these kids are seen in outside hospitals, and they're really not assessed. They're just almost immediately transported down here because people are afraid to do anything with these children. So we'd like to actually help them kind of feel more comfortable and troubleshoot some of these things. So we're not spending so much healthcare dollars on just transport and having them be seen localized. We've been contacted from some of the healthcare nursing companies. As I mentioned earlier, Western Pennsylvania has a has a pretty significant shortage of qualified healthcare providers that will care for kids with tracheostomies. And part of that is they don't feel that they have enough education. So they've contacted us to help educate them and prepare them for better handling situations with kids. And then even within our own hospital system, some of the nurses within the ICUs have actually reached out to go through this. So that's our next step, and we'll study that with very similar questionnaires. And so more data to come. This is just some of the other steps that we'd like to take for some of the healthcare providers with the pre-training survey, online simulation, and then the video feedback, and then surveys. The other thing that we've created with part of this is through Wiser, and I'm not sure if any of you have ever taken any of the courses through Wiser, but they have a lot of online material that's accessible, as well as other tests and stuff that they can do. And so we're hoping that some of the healthcare providers will have access to that as well, which will help them keep up with information, not only the one-time simulation that they might do, but also keep more up to date with stuff. So I just want to say thank you. I wanted to thank everyone at the Airways Center staff, specifically Katie Williams and Jen McCoy, who might actually be on. And then the respiratory staff at Children's Hospital has also been very helpful. We have 2 main respiratory therapists that know all of these trach families and know their needs, and they go out of their way to help these families significantly. I wanted to thank the Beckwith Institute. And then I also wanted to have a special thank to Angela Foker. She runs a program called Precious Baby Photography, and she shot the photo that's in the back, and she goes around and provides services for a lot of these highly complex medically challenged kids, and takes photographs for the family. So that's it.
Well, thank you so much. Dr. Toby, this is one thing that I think, we talk a lot about the research that we're trying to do, the ways we're trying to advance care, the way we're trying to move care forward to make care better for patients. That's really what we try to do through the Eye and Ear Foundation, and it's really the focus of our work. Showing people how to care for their loved one that is dealing with these issues, especially a child, is something that you can't put enough emphasis on. It's very direct and it's very hands-on, and how much you can improve that by just education and finding different ways to do education. It's really important. How much, I'll start with the questions. The questions are open, folks. Please put questions into the system and I'll read them for you. We already have two, which I'll get to. But I have a question first. So how much, in addition to training, these techniques are very advanced, even, putting, the trach in a child, a small child. I know because we wrote a story on it in our Sight and Sound newsletter. You've even done this in utero with people, which is, it's mind-boggling. How difficult is it to train our young surgeons in training, our residents, in these procedures? And are there more tools or things that are important to that or simulation labs and things of that nature that can be useful?
So we do have training. The actual procedure of putting a tube in is not as hard as it sounds. We're training our medical staff and our residents how to care differently for a kid with a trach than an adult. I think is different. We do have simulation itself and put the tube in. But that is relatively a more straightforward thing for them to learn. What I think is more important for them to learn is what happens with children is they move around a lot. They grow a lot. As they grow, their trachea is much higher, or so their larynx is much higher, and then as they grow, it moves down. If you have a tracheostomy tube and you have some rapid growth over a period of 4 or 5 years, that whole neck area changes. The other thing that changes rapidly with kids is the diameter of their airway, and the size of their tube might need to be changed quite a bit. And then movement affects it. So kids have to be monitored more closely for adjustments in the size of their trach or changes to the phalanges around it, as well as the area around it that can get something called granulation tissue that needs to be treated, because that can actually cause significant obstruction. So kids with trachs need much more closer monitoring than an adult with a tracheostomy tube. And so teaching them that's something that I just think comes with experience and kind of through videos. And I have some families that have sent me some, mostly just like wound stuff that is important for our trainees to know about and to know how to manage.
Well, thank you. We do have a few questions. So what medical conditions, what medical conditions would result in child's jaw and or throat being too small or, needing a tracheotomy?
Right. So that's a great question. So we did do a story for a Sight and Sound before that had a nice example of an abnormality that would require a tracheostomy tube. It was a child who had a very large tumor in the neck and mandible. And sometimes those are identified in utero. So sometimes things like that, if you have very large tumors of any of the facial structures or in the neck. There are a lot of craniofacial disorders where the jaws are too small and the tongue pushes back and it causes obstruction of the upper part of the airway. And those are very common. As you grow, the jaw grows, and there are some surgeries we can do to pull the jaw forward, but it might not be for several months to years sometimes until those surgeries can be reformed. Other syndromes, such even Down syndrome is one where the face is smaller. There's bony, the maxilla, which is the bone of the middle part of the face, is too small and pushed back. There's a lot of other craniofacial syndromes that come with structural bony abnormalities where their airways are just small. There are lots of surgeries we do to improve those airways, but like I said, a lot of them do require the child to be older, and we need them to be able to breathe so they can grow and get to those surgeries.
Wow. Now here's another question. Is the simulation lab for tracheotomized infants located within the hospital itself or an adjacent building, like an educational setting? Yeah. And does this increase risk?
Oh, so it is located in the hospital itself. It's on the second floor of Children's Hospital. So we don't bring the children in, it's just the families. And we are, at this point right now, the families that are going through the training system, the children are still in the hospital. So they have not gone home yet. So as far as an increased risk, I'm not sure what the question is, if we're going to expand this to other healthcare providers, would it be nice to be able to do this at an outside facility? Yes. And we could probably do that.
Mm-hmm. I imagine that it would be helpful for some of these families to be able to do it in their homes.
Correct.
Is that possible? Okay.
We're not quite that mobile yet. So, no.
You can't send a package to the home and then do yeah. If for people who may not see this, I mean, they're it is a simulation lab. Usually it's a mannequin and it's almost like a real hospital setting where you would do all the things that you would need to do to
yeah, we have converted the room so that at least part of, like, 2 of the walls look more like a child's bedroom. Okay. But yes, if you turn around, it still is a typical simulation. Mm-hmm.
Okay, so great presentation from one of your colleagues here. Are you doing or planning to do periodic refresher training? And if so, how often would you do it?
So we haven't really talked about that. We have offered it to families, but we haven't made it mandatory by any means. We are here to serve our families. So if any family would want to do it, we could make it happen. It just has to be coordinated. Mm-hmm. But yeah, we haven't set anything up specifically. Now, if we do healthcare providers, that might be something that we decide to do once a year. Is what we had talked about.
So it's kind of a follow-up to that is training for health professionals and families who live outside of Pittsburgh offered. And are these partners with health, are there partners with health centers in more rural parts of Pennsylvania?
So at this point, we don't have any of those set up. And we haven't actually been offering it to anyone that's outside of the children's system. Our ultimate goal would be to have that availability and to have it more localized to where they are. Our NICU does travel with their simulation stuff to other outside facilities. And we'd ultimately like to have something like that. But it's not set up yet.
Now I'll add to the questions here. This is, I kind of alluded to it. Is there a way to do better training for parents in their home, using some of the telemedicine type of, technology that's now opened up because of COVID?
Right. So that's a good question. So we can do some of the training via telemedicine visits and things like that. Now, as far as, but a lot of that's us talking them through things. They can show us the wound. They can show us how they suction. So yes, that's available, and we are doing some of that stuff. As far as having them run through an emergency situation, that's a bit hard. And then also the problem that we come in with a lot of these families is if they want to show us how they do a trach change, sometimes, I mean, you saw the problems that we had with trying to set up the phone, just getting a good location and us being able to see what they want us to show us. So that is a problem. But ultimately, I would love it if we could have some type of way to look at these kids' trachs, look down their trachs. So when we see them in the office, we often look down to make sure there's no scarring or issues. I would love to be able to do that from home, have them do it from home. We're just not there yet.
Well, maybe that's in the future. Who knows? So, thank you. This is certainly, again, something that we want to make sure that people understand that advancing care is not always just research, like in the traditional sense, the bench research and trying to, move care forward, but also just looking at how we're teaching patients, teaching families, teaching healthcare practitioners on how to care for people and doing it in the best way. So thank you so much for sharing this with us and our audience. I'll give it another. It looks like we're done with questions. So thank you, and everybody, please have a wonderful Friday and wonderful weekend.
Sounds good. Thank you for having me.